Okay, welcome everybody to this meeting of the Health Overview and Scrutiny Committee. My name is Ewan Walters, Senior Democratic Services Officer. This meeting is being broadcast live to the public via YouTube and will be available for viewing on YouTube after the meeting. Could I please remind you to turn your microphone on when you're speaking and then turn it off when you have finished, okay? So we've got a lot of new members on the committee this year, so welcome to you all. There's been one late change to the committee membership as listed on the agenda. Mr. Nick Chapman's replaced Mr. Simon Bradshaw, so welcome to you, Mr. Chapman. And I would also like to welcome the new Cabinet Lead Member for Health, Mr. Michael Squires, so welcome to you. So we'll move on straight with the agenda. The first agenda item is appointment of chairman, and Dr. Sarah Hill was nominated as chairman-elect at the annual meeting of the County Council on the 14th of May. Could I have a proposer and seconder that Dr. Hill be appointed chair, please? Mr. Piper?
Yes, I'll propose.
And a seconder, please?
I'll second.
Thank you, Mr. Cook. And everybody in favour of that motion? That looks unanimous. Thank you very much. So that's passed, and Dr. Hill is now appointed chair for the 2025-26 council year, and I will hand over to Dr. Hill for the rest of the meeting.
Thank you, Ewan, and thank you for confirming full council's decision. Next item on the agenda is election of deputy chairman. So do we have any nominations for deputy chair?
Nominate James Poland.
Okay, and seconder? Thank you. Do we have any other nominations?
Yes, I'd like to nominate.
And a seconder, please. Okay, as is traditional, Ewan's going to come around with his magic piece of paper and we have a secret ballot. So we'll let that take place.
Okay. So the result is 6 votes in favour of Mr. Robinson, 3 votes in favour of Mr. Poland, and 1 vote, one is abstained. So Mr. Robinson is elected deputy chair. Thank you.
Thank you. Right, we'll move on to the minutes of last meeting. I propose they were taken as read and confirmed and signed. Does everybody agree? Thank you. Right, now move on to question time. We've had two members of the public. We have two questions from a member of the public, Rachel Moore. Who is she joining us virtually? Oh, you're here.
She's here.
Thank you. One about GP appointments and one about suicide prevention. Written answers to the questions have been provided and published on the website. Supplementary questions are allowed to be asked for the purposes of clarification. They must be related to the substance of the original question, not introduce any new matter which did not fall into the scope of the original question. Rachel, do you wish to seek any supplementaries?
You only get to ask a supplementary question. It's not about making a statement today. So it's just for clarification on the answers. Well, there isn't a procedure for members of the public to make statements unless the chair particularly wants to allow it. Sorry? One supplementary question, yeah. Okay. You will need to come to the front of the room so the people watching on the webcast will be able to hear you if you use the microphone.
I'm not used to speaking in public or anything. My daughter died by suicide last November. She was able to jump from the 7th floor of the High Cross car park. She was 27. She was a teacher at the Lawn Primary School in Overby with a first class honours degree. And she was able to jump from the 7th floor of the High Cross car park. I wondered if somebody could look into making it safe so nobody else does it.
I'm sorry what happened to you. That is just awful. I can't think of the right words. It's something we'll take away outside the meeting and see what we can do.
She was able to jump down the stairwell.
Really?
Which was
no.
Not a safe. Obviously, the rest of the car park is safe, and she was able to jump down the stairwell. There's no mental health crisis support. And in your thing, you've said about support for bereaved people, and there was nothing for us.
Yeah,
and it's been absolute living hell.
Okay. We'll take the point about the High Cross outside of here and see what we can do to contact the owners. Thank you. Yeah. Okay, well now I'll move on to the next item on the agenda. There are no questions been asked by members under the various standing orders. I have not been advised of any urgent items. Does anyone have any declarations with respect to items on the agenda? Thank you. And I'm assuming there are no declarations of the party whip. Surprised if there was. And there are no petitions under Standing Order 36. So to the first main item on the agenda, the Public Health Overview and Annual Report, which is going to be presented by Mike Sandys, the Director of Public Health. Over to you, Mike.
Sorry, I missed a point about declarations of interest. It's probably I am a member of a pressure group which is trying to keep hospital open in Lutterworth. So that will come under probably the later words when we've got members of the LLR here as well. The group is the Mary Guppy group based in Lutterworth.
Okay, thank you for that. Mr. Squire.
Thank you. I'd like to make a declaration in respect of me working within LPT. Looking at the items on the agenda, I don't think that I would need to leave the room, but I'd just like to declare it anyway.
That's good practice, thank you. Okay, Mike, do you want to pick up? Thank you.
Yeah, thank you, Chair. I'm acutely aware that a number of members around the room will have attended the public health member induction briefing just now. So I'll try not to duplicate everything we said. In terms of this report, obviously a different venue, to give you a bit of background, obviously we've had many an item from public health that have come to scrutiny over the years. They have largely been about scrutinising from the committee some of the work or our service redesign proposals, for instance, where we have had to redesign services or cut services, and we take that to scrutiny as part of the decision-making process that ends up at Cabinet. What we hadn't done until last year is to bring to scrutiny a kind of overview of the work of public health, which looks at the breadth of what we do and why we do it. It was a suggestion I picked up from another DPH when I was doing a professional appraisal a couple of years ago, and I did think it was a good idea. So last year was the first time that we'd brought such a report to Scrutiny Committee. This one comes to you today as a kind of our annual review thing. Obviously, it's probably not badly timed given the fact that we have got a number of new members in the room today. In terms of content, I'll largely take it as read. It covers what is public health, what influences our health, our statutory duties, both in terms of individual services like the need in paragraph 8 to provide open access, comprehensive sexual health treatment services. It covers our funding. And again, members will know, members of old will know, and members who were at the briefing will know, we are a low-funded authority from Department of Health when it comes to public health activity. We have our departmental strategy, which is delivering good health and prevention services, which has a number of building blocks, which we've included as Appendix A for information, which is basically working with our communities, providing services that meets needs, and promoting healthy living in healthy places. And then from paragraph 15 onwards, we do give an overview, both in terms of our services that are commissioned externally from providers such as LPT, UHL, or the third sector, such as Turning Point for our substance misuse services, but also the scale of delivery that's provided by our in-house delivery, of which Adrian Allen, to my right, one of my assistant directors, oversees the work of that department, of that part of the department, particularly in relation to services like local area coordination and our integrated lifestyle service, which picks up on issues to do with smoking cessation and weight management. It also covers sections on the depth of our partnership working. Again, a really key part of activity for the department is the work we do in partnership with my NHS colleagues around service redesign, clinical pathway and development, where the public health prevention bit is an integral part of pathways for people at risk or with illness, and including mental health in relation to the previous question, but also involves stuff around our role to do with being statutory consultees around alcohol licensing, and our work with community safety partnerships, both at the county level and at the district level. And then lastly, it also involves work from paragraph 29 through until 32 on our work on what's called the wider determinants of health. So where we work with, for instance, districts to make certain that they consider health issues within their local plans around housing and economic development, because that is a key way by which we can affect good health for people in Leicestershire outside of just providing services. And having said lastly, I did miss out a couple of bits in relation to the 3 domains of public health, one of which is health protection. So paragraphs 33 and 34 put a number of bullet points down in terms of the work we've done in the last year, working with ICP colleagues and council colleagues around infection prevention control and our role in outbreak management with those colleagues in, for instance, care homes. And then in terms of healthcare public health, there's much I could say in terms of the advice and support we offer to our NHS colleagues to make certain they are making certain that everything is evidence-based and appropriate to need for people in Leicestershire. But we've just highlighted a couple of extras in terms of money that we've got to, for instance, in paragraph 36, understand any relevant issues as to why people aren't able to manage their asthma effectively, which could be to do with issues to do with inhalers. It says inhaler technique, finances, or other issues. So more than happy to go into detail on individual bits, but it's a broad overview which we bring to committee for scrutiny. So thank you, Chair.
Thank you, Mark. Questions, observations, things you want to say about it? Mr. Page.
Thank you very much for that. I attended your previous briefing, so I don't want to dwell on this too long, but could you just confirm for me, on a per head of population basis, if we were treated the same way as Leicester City, what would that total funding envelope look like?
So we receive £40, I think £40.65 per head of population for public health work. Leicester City receive £87.50. Obviously, Leicester City's population is not as large as us. I'll look to my learned friend to my right, but I'm pretty certain that in absolute terms, the city's budget is about £1 million more than ours, despite us having over twice the population. Am I right? Yeah.
I know the city has high levels of need, but that's quite a substantial difference, isn't it?
It is. I mean, again, I wouldn't disagree that the health status of people in Leicestershire is better than people in Leicester City. I kind of understand that. The only thing I would say is, when it comes down to unit cost of providing services like smoking cessation and weight management, is there a particular reason why Leicester City services would cost twice as much per head to run? So, the scale is there, if you like, the need is probably greater, but I don't know if that translates into a difference in per unit running costs.
Over the years, we've changed. I was looking at the commissioning, internally commissioned and externally commissioned stuff. You've changed the way a lot of our stuff's done in a way that I guess works for rurality as well, in terms of it's easier to deliver now over a big area than it was.
Yeah, obviously Adrian in particular has been key to that in terms of redesigning services like the smoking cessation service. I don't want to make a virtue of austerity, if you like, but one of the things that our constrained finances did do meant it did force the issue around looking for innovation in the way we deliver services, and actually using digital channels, telephone, web, probably has got the benefit of it's not just cheaper and more cost effective, but for the same, we still get more bang. Well, we get more bangs for the reduced buck. And actually, one of those things is I think it's that model of working is a way of providing something that's more accessible for people in the more far-flung parts of our county. Yeah.
Thank you. Any other questions, Mr. Crooks?
Is the issue of funding going to get worse as the population increases with developers? So obviously GPs get Section 106 to help with the additional needs, but what about our department?
Less so. What we are, I suppose, we are at the mercy, whether one likes it or not, of the Department of Health and Social Care when they give us the grant allocation at the I was going to say the beginning of the year. We're lucky if we find it by February, going into April of the financial year. That should take account of adjusted population figures, so the ONS population estimates. Clearly, if you're in an area that's got substantial housing growth, you might argue that between censuses, the reliability of those mid-year estimates get a bit ropey. So if you're in an area with more substantial housing growth than an area that had less, you might argue you might have a bit of unexpected, unaccounted for pressure. But I think the main bit for me is just being at the whim of DHSC in terms of how much they give us. So last year, or going into this financial year, we were budgeting on a 2% increase. We got 5.4%, was the biggest increase we've ever got. That meant we didn't have to cut services in the way that we thought we would have to. Do I think we'll get that scale of increase in future years? Probably not. And if the grant doesn't keep up with pay rises and inflation, to be honest, we've always got a cost cutting target because we have to manage our own smoke.
Thank you. Mr. Page again.
Sorry, just changing tack now. Section 19 in the report. It says you undertook a study on oral health, and quoting you, you're currently working with internal and system partners on the recommendations. And that study was dated 2023, or that work was dated in this report in 2023. So forgive me, but that seems like quite a while ago. So in which case, considering that this area remains a leading cause in childhood hospital admissions, have I misread it in terms of the date and the actions that you've been undertaking? And if you have been following recommendations from that, what outcomes have we achieved for oral health?
So we did do the Joint Student Needs Assessment, JSNA chapter back in 2023. You're right, there's probably more about what's in paragraph 20 as the response to that one, which includes our programs of work around oral health promotion, supervised toothbrushing, it being a sad fact of life that, you get children in primary schools who don't know how to use a toothbrush, so it's a bit of a shame to some extent that we have to go in and do that, but that's certainly one of the things that we've stood up in there, as well as reminding dentists around the application of fluoride varnish in children as well, which is part of the dental contract. So I'd actually say, yeah, the JSNA has been done, and that's then led to the work that's been going on in paragraph 20. And you're right, actually, just to correct you, it's not one of the leading causes. Of course, dental tooth extraction is the leading cause of children's hospital stays, I think, isn't it? Number one.
Can I just ask a supplementary then to that? So in terms of measuring the effectiveness of those things, what metrics have we got to see that we're actually having an impact on the things that we're doing here?
That'll be our DMFT scores. So the score of whether you have decayed, missing, or filled teeth, DMFT. For some years, or at least when we came over from the council, Leicestershire's DMFT score was not fantastic. Leicester City's, I think, was the worst in the country, and the counties wasn't far off. Over time, we have pulled ourselves up to be well out of the relegation zone. I'm hoping Adrian could tell me exactly where we are on that one. So I'd be the first to say I don't think overall health in the county is, we've got still space to go, but it's good to get out of the relegation zone into mid-table, if you like. Now, how much of that is the work of the small oral health promotion department? How much of that is societal changes or whatever? You could argue the toss, but I'd like to think we played our part.
Thank you. Now, Mrs. Barber would like to come in. She's from Health Watch Leicestershire, and they have a seat at the table from their unique perspective.
Thanks very much, Chair. We have a seat, but not a vote. I think I should point that one out. Firstly, I'd like to say to the Director from Health Watch, this is a really cracking report. It just encapsulates some of the wonderful work that public health has done across the county. Health Watch are really pleased to work in partnership with public health on a number of issues across the year. And I think that bodes well for communities. One of the issues that I don't think I can read clearly in the report, and no doubt the Director will put me clear, is really we pick up quite a bit that communities don't really understand what public health is, what it's responsible for, how it can help them. And interestingly enough, particularly when you think about the work that could be done in line with prevention, and some of the work that you kind of hint at in the strategy going forward, whilst there isn't a separate paragraph around prevention, prevention is obviously quite key and a really good baseline to develop healthy practices, habits, what have you. But if communities don't really understand public health, it makes it very difficult to develop that prevention conversation with communities. And maybe that's something that public health could develop going forward to make it much more meaningful to some of those communities around the county. We talk about outcomes, and I agree, oral health coming out of the relegation zone is a really good level indicator. However, one of the issues that Health Watch picks up time and time again in the county is access to NHS dentistry, not just for adults, but for children. So actually the relegation area is quite a low aspect, and even mid-table is perhaps not where Health Watchers right across England would want it to be. It's not just something that's relevant to the county, but it is an area of concern, and it's one that Health Watch does get feedback on from people out in the communities. Having said that, I think one of the things going forward in terms of measuring how successful some of the outcomes could be is actually hearing firsthand from communities and shaping that as part of the outcomes. Because whilst it's great to know that, we have a really good smoking cessation services and sexual health services, hearing from those people and weaving that back into the feedback for the annual report is a really good idea, because it tells the human side of the number crunching, and it really allows us to get a true picture of how the services are impacting on individuals and communities in there. So that would be, I think, for Health Watch talking forward, great report. Can we see it develop even further for moving forward into the next 12 months, possibly? Thanks, Chair.
Thank you. Thanks, Fiona. I'm gonna have to play it back, because I'm sure at the start you called me Director of Public Health Watch. Yeah. Careful what you wish for.
That could be a new
It could
set
be.
altogether, couldn't it?
Yeah, more pity. I pity you if that's the case. It's interesting. What's public health? Yeah, you're right. I guess because public health work is so broad, it can be difficult to put it over. Some of me also thinks actually, does it really matter as long as people know us by our work? So I mean, you know, I know people always go, I remember, people do, you know, people still go, I remember you on Radio Leicester during COVID. It's like, well, yeah, that's part of the work. I think in terms of services, I like to think that people that need it know our services like Quit Ready, Weight Management and Local Area Coordination Service. We are doing a piece of work. We haven't launched it yet, but I suppose it would be wrong of me not to say we have got a plan. And again, some of those individual services like the smoking service, the weight management service, I would like to bring them together under a kind of Healthy Leicestershire banner, because that might just then help people see the breadth of public health services that are there. Whether if that improves their visibility, then maybe that is something we can take forward. Having said that, having said that, it's about public awareness. I think with the NHS, and of course I've got my NHS colleagues over there as well. I mean, they're very well aware, I suppose, of the part that we play in those prevention pathways. So any of the clinical pathways around lung cancer or COPD or whatever, you know, are going to have prevention at the start, and it starts with us. So, you know, do I want to be recognised on the street? Not really. Do I need to make certain that people know what our services are and they use them? Yes. Do I also need to make certain that the NHS knows what our services are? And I think the answer is a big fat yes from that point of view. But I mean, we can always strive to do more.
Okay, thank you. Any other question? Thank you. Interesting report as always, Mike, and it's good to see how things are moving. It's good news on the dental stuff, because I remember when that first all broke. So thank you. And we'll move on to the health performance update, which means a quick shuffling round of people, I fear. While we're doing that, I'll just read the bit out I've got here. I must clarify the purpose of this report is to enable the committee to identify areas for more detailed scrutiny at future meetings. The officers at the meeting today won't necessarily have the knowledge for an in-depth discussion of all the issues referred to in the report. So we've got here Andy Brown, who's the Business Intelligence Team Leader, Leicestershire County Council, Yasmin Sidiot and Rachel Deere from the Integrated Care Board, and Victoria Rice, who's on the screen, Public Health Intelligence Business Partner, who's joining us online. I did think that it might be sensible to do the ICB stuff first, and then the public health stuff sort of second, just to sort of make it easy for councillors to get their head around it. But Andy, do you want to introduce this?
Yes, please. If I could just say a few words in introduction, just to explain a little bit about the report you've got before you, particularly for new members of the committee. You may be aware that under the council's corporate performance management arrangements, we do take regular performance and data reports to all of the scrutiny committees, very much based around the county council's strategic plan and the relevant metrics that support that, but also those underpinning key strategies that the organisation's working towards, health and wellbeing strategy, the public health strategy, and also in this case, the ICB strategy and some of the national priorities around health. So we're really looking to capture that headline picture of progress, performance, and be very transparent about the data. So members of the committee can see and ask questions about performance, progress, priorities, and some of the data. We are conscious there's a lot of data in the report, and we're very much open to views of the committee as to what's the most useful style of report for the committee. And we have adapted that over the years, sometimes to bring more data in, members particularly interested in certain data, sometimes to streamline it a bit if you're getting a bit too much data. So happy to take the committee's view on kind of the style of the report, but we are looking to meet certain requirements and hit certain key data points. So in terms of this report, it's really a three-part report. There's the ICS and key national priorities around health, which colleagues in health are going to talk about in a little while. There's the public health section, which picks out 36 metrics that are key to the public health department strategy and key interventions. It's a subset of the public health outcomes framework, so there are 100 odd plus more metrics that sit above that, but it is the key metrics that it hits on some of those interventions and key priorities. And then there's the Better Care Fund report, and members may be aware of I think it's an £80 million fund now for Better Care, which works both into adult social care, in terms of preventative services, but also fund some of those interventions that fall between health and care, particularly preventative services, new services, and supports health and care integration. So it's looking at some of the metrics around that area. So really three key areas, and quite a lot of changing as well. The County Council's working on its new strategic plan, so you'll start to see that come into the system potentially later this year. So we will take account of that moving forwards. There is a new health and wellbeing strategy as well that's being worked upon, so we'll look to sort of bring that forward and reshape as a result of that. And you'll see in paragraph 4 onwards, there is a lot of change going in to the kind of national reporting around health that have been introduced by the new government that is now starting to feed through into reporting arrangements and new planning for health. So we are a little bit caught between the two. So we're backward looking largely in the data. So a lot of it looks back to the old system, but we will be introducing these new metrics and priorities, particularly those that are highlighted in paragraph 6. Some of the national priorities on improving referral to treatment, improving access to emergency wait times, access to general practice, patient experience, dental care, and mental health crisis support, all sort of flagged in those national priorities for 25/6 onwards. So we'll look to pick that up moving forwards. And paragraph 7 talks about some of the underlying key priorities to support that around neighbourhood services, digital tools, etc. So I may be straying a little bit into my colleagues' territory, so I'll kind of hold at that point in terms of the report. Happy to take a question on that, or hand over to health colleagues just to take you through the sort of the main bit of the report.
So there's no questions for Andy. I'll let them crash into the, well, that's the wrong phrase, carry on into the health stuff. Thank you.
Thank you, Andy, for that introduction. Just to introduce myself, I'm Yasmin Sidia. I'm the Deputy Chief Operating Officer for the ICB. And I'm here standing in for David Baxter, who is our Head of Performance, who would be usually here to take you through the report. So I do ask people to bear patience with me, but I will take questions, and those that I cannot answer today, we will definitely endeavour to get back to you as soon as possible. Andy has covered in terms of where we are at the moment. So we are closing off our sort of performance reporting based on the previous framework and moving to the new framework, although some of the broad priorities stay pretty much the same, particularly around the 4-hour performance around urgent emergency care, A&E performance, ambulance handover remains a priority, GP appointments and expanding the capacity in general practice remains a priority, and the bit around waiting times, particularly around cancer, remains a significant priority as well. That doesn't mean that there's not a whole wealth of other work that is going on. We have still got some real key priorities, particularly around mental health and access to mental health services as well, and LDA as well. So that's kind of the priorities. We know that we've got huge amounts of work to do. It's not perfect by any stretch of the imagination, but there have been improvements, although incremental improvements, that have taken place, and we understand that that work doesn't stop, it continues. I wasn't going to go through every single thing. I think there's a huge amount of information there. So what I was going to do is open it out to any particular questions that members have got around any specifics that are within the report from a health perspective, and take those specifically.
So questions, ladies and gentlemen? Can't believe there's none. Mr. Poland.
Thank you, and thank you very much for the report. There's obviously a lot of information here, and you know, and I think it's visually quite a good way of putting it out. So I thank you for that. In terms of the performance priority summary, there's a number there that interests me, but my question's about the second one under urgent and emergency care and ambulance response times. It's something that, thankfully, my family haven't had too many reasons to call ambulances, but I'm aware from friends and family that have that the response times can be quite significant. One brief example, my son, who at the time was 3 years old, last October broke his arm phoned up the ambulance, and the woman was incredibly helpful. Couldn't have been helpful, more polite, more friendly. But they were saying it was going to be a minimum of 8 hours for my 3-year-old who was screaming on the floor to get an ambulance. So in the end, I had to get my football scarf, make it into a makeshift sling, and drive him to the LRI. And I have concerns over that. There was a time when you phone up 999 and you'd be confident you'd get an ambulance. And now I'm just not certain that if something happened to one of my family today, if I phoned the ambulance, it would actually turn up. And that's quite a worrying situation. My question, though, is this. I appreciate a lot of that is national, a lot of training places for paramedics, funding issues and all the things. But to what extent can we influence that locally? Is there anything we can do locally to improve those response times for ambulances?
Yeah, I'll take that question. So my name is Rachel Dewar, and I'm one of the associate directors that works and have a responsibility over, excuse me, urgent and emergency care. So we're doing a huge amount of work locally, and yeah, absolutely, we can influence this locally. So the work that we're doing has 2 elements to it. One piece of work is very much focusing on what we call POAs, which is patients on ambulances waiting to go into the ED department. And the reason that's really important is because the longer we have an ambulance waiting to offload a patient into our ED department, then the longer it's going to take for them to go and be able to respond to another case. So we're doing a lot of work on that, and we're part of a national programme around reducing those wait times, and I have to say that we are beginning to see the fruits of that, and we're beginning to see some real improvements in the work that we're doing. The second part of that is working across our system. So the category 3 and category 4 calls, which are the calls of a lower acuity, we have a process in place where they are being passed across from East Midlands Ambulance Service across to our 111 services in terms of being able to respond from a different service, which means the more that we can reduce those lower acuity calls going through to East Midlands Ambulance Service, the more that they have the capability and the capacity to deal with those higher acuity calls. And our category 1 and category 2 waiting times are something that are absolutely under scrutiny every day locally, but formally every week and every month. And we have regular meetings with NHS England around where we are sitting with those response times and how we're doing according to the expectation of our category 2 calls being within that 30-minute time zone. We're not quite there in terms of hitting the target, but we are definitely making improvements in those areas.
Just so you know, Mr. Poland, I'm told that EMAS will hopefully come into our November meeting. So we live in hope. Do you want to come back on this, Mr. Squires?
It's a separate question, actually, if that's okay, Chair.
Thank you for that. I'm going to make a bit of a personal declaration here in terms of the mental health area here. So I have been a recipient of some of your services. I've suffered mental health issues for most of my adult life. And in the last 3 years, I had recourse to use additional services because I was myself under threat of suicide. And I'm very interested in your talking therapies report here, because my concern is that this is about throughput rather than output, and what the effectiveness of that is. And let me just express that from the point of view of someone who was offered talking therapies, sitting in front of a screen with PowerPoint slides and being spoken at a time of my greatest vulnerability, was completely ineffectual. And if it wasn't for the fact that I am successful enough to be able to kind of resource my own care and have the therapy that I needed at the time, and to have a dedicated mental health specialist in my GP practice, I don't think I'd be here. As a first line of intervention, I find it really difficult that we're still thinking that the internet and web services provide the solutions for everything. It may be cost effective, but frankly, I'd like to know more about how effective that actually is, because I cannot understand how people at suicide risk, alongside people who suffer from anxiety, are all lumped together as if somehow this is a cohort that can be treated equally. And so I'd like to see some further thought about how those services can be developed. And I'd like to see some further analysis on the actual outcomes and effectiveness of these services.
Okay, thank you. I think that in terms of answering that question fully, I think it would be helpful if we perhaps suggested that we had a mental health specialist presentation coming to the meeting. But what I can say to you now is, in terms of the work that's happening, we've done a huge amount of work with our talking therapy provider around the range of services that they offer. Some of those should be face-to-face, some of them should be online, and how they triage patients to identify them into the appropriate place. We've also done similar work with our mental health cafes and some of our additional support services that we have available. But I think in order to answer the question more fully, I think it would be helpful if we asked our mental health colleague to come along and do an update for you on the mental health services.
Just to say, though, that one thing I will say is that the speed with which I received intervention was very fast, but I had to know how to do it.
Yeah, which can be a challenge in itself, particularly if you're not feeling yourself.
Well, if you're overwhelmed by everything, it's really difficult.
And you're depressed, you can't be bothered to do it.
Absolutely right.
So yeah, I think that's something we're going to have people in to talk to us about, which sounds awful, but have LPT, have a discussion, particularly about AAPT, which has been not brilliant for a while. So yeah, so I've got a few people now, Mr. Squires. Yeah, I think that's something, again, when we get them in, we need to have a conversation about that. So thank you. Sorry, Mr. Squires.
Yes, just to say, Rachel, if you could send me an email, I'd like to be in touch with you at some point. So my question was, in terms of the central access point, is there much evidence that that's being utilised well and shared amongst clinicians and generally used appropriately? Because it's a really good service for people that are in crisis.
Yeah, there is evidence of it being utilised well, and there is evidence of the hub being used really well as well. And again, I think we can give you greater detail on that as part of a more broad conversation. So we have central access points for our services. We are doing a piece of work at the moment in terms of recognising that when we talk about single points of access, we've actually got several single points of access, which is kind of counterintuitive in terms of people seeking help. So there is a programme of work happening at the minute called our SPOA programme, which one of our heads of service, Kerry Core, is leading on, and that is looking at how we take those points of access and create a single overarching point of access, which will make it much easier to streamline patients and people seeking support into the correct pathway. So that piece of work is happening at the moment, and it is around working with all of the organisations across Leicester, Leicestershire and Rutland to integrate those services into a much more robust single point of access, and that I think will be incredibly helpful.
Thank you.
Thank you. Mike, you just want to come in briefly?
Yeah, thanks, Chair. It's just in terms of helping with agenda planning for the mental health item, and maybe to help Rachel and colleagues think about who to invite. Can we just sort of nail on the head exactly what we want to come in? I'm just aware mental health services is such a big area. It's probably just being clear. Are we talking about talking therapies or early intervention for those with suicidal ideation? Just want to make certain we don't end up, we could spend hours on mental health because it's so broad, but not.
I think early intervention is a critical factor.
The early intervention at stroke IAPP, because that's where a lot of people first go into it. So I think that rather than the inpatient and all the rest of it. Thank you.
Yeah, I was going to ask the same question to just get the specifics so that when I go back to the team, we do have a mental health collaborative. So what I'll do is I'll take that back to the collaborative, and then they will work through as a team, and that spans across Leicestershire Partnership, our voluntary sector organisations and the ICB in terms of who sits on that collaborative.
Thank you. James.
Thank you. It's just I didn't declare at the start because didn't think I needed to, but because we're spending quite a lot of time talking about mental health, I just want to put on the record I'm a trustee of the Loughborough Wellbeing Centre, which is a leading mental health charity here in Leicestershire, and obviously we spend quite a lot of time talking about that, so I think it's probably right that I put that on the record. But just to repeat the call, just thank down to the page for sharing that. It's obviously very personal information, but it's just so important that we hear from people, and you know, all about the experiences we have, because it is so key, and it's the experiences of survivors and of family that is so important. So very much early intervention. What can we do to stop people getting to the point where they're at crisis? It's just so important.
Thank you, Mrs. Barber. Thanks, Chair. Firstly, Councillor Page, thank you for sharing that. It makes our work all the more intense when we hear people sharing their first-hand experiences with us, and it really hones the way that we look at the work that these committees are actually tasked to undertake. So from Health Watch, thank you very much indeed for sharing. Just sticking with that topic for a moment, members may be aware, and Mike will no doubt jump in, that there is a recently renewed suicide prevention strategy, and currently there is work underway led by Public Health, Mental Health Lead, to look at the sort of actions that could be taken in terms of the suicide prevention strategy. So now would be a very appropriate time, perhaps for members around the table to share their experiences through the Public Health Department to help shape that strategy as it develops. The other thing I wanted just to check on, I'm sure NHS 111, haven't they introduced a separate phone number for mental health? Am I not thinking 112 or something equally?
Yeah, there has been conversations about it, but at the moment, you when you go through to 111, they will put you straight through to the appropriate mental health support. But there isn't a separate line for that at the moment. It's kind of 111 and then through to that support.
Okay, thanks. Probably getting a bit ahead of myself on that one then, so sorry about that. Chair, I'd like to ask a question around GP access, if that's okay. So Health Watch has for a number of years had the topic of people being able to access or get appointments with their GP fairly easily. It's an old chestnut, and again on page 90, I think it is, of the papers, we see it appear here again. Now, obviously, recently, for example, Health Watch in the last 12 months have had 381 inquiries about accessing GP or hospital appointments, and of that 381, 333 related to GP appointments. So whilst we call it an old chestnut, it's still burning quite nicely, roasting away on the grill there. So the reality is, it's great that every year we are increasing appointments, and that's obviously because there is a demand. But how can we level out the demand so that it is apropos of the services that we actually have available? It's not just people need to see or speak to a GP. It's much more an issue about understanding health issues and where they're best serviced. So pharmacy first, should we take it to a pharmacy first, or maybe the practice nurse or practice pharmacist rather than GP? What is it that's causing this, and how can, going forward, how can that be made much better? Because otherwise we'll be sitting here in 12 months' time still talking about GP access for GP appointments.
Thank you, Fiona, and you know that we've been talking about this for a very long time. And to put it into context, when we talk about GP practice access, we are talking about GP practice access across 150 practices across LLR, all of varying sizes with varying sort of capabilities. And restrictions in terms of the estate that it works from, the staff that it has and employs, and you're working with sort of 150 different individual providers of that service. This is where the complexity of trying to deliver something at scale, when you're also trying to make that as nuanced as possible for that practice's population. And that's where the challenge is. And we've made loads of improvements. I think there is some real good improvements that have been made. Year on year, despite the challenges, GP practices are delivering more and more appointments. This 24-25 across LLR, and if people want county-specific data, I can get that. I just didn't have it to hand today. Is about 7.8 million GP practice appointments that were done, and that's not just to seeing the GP. That's seeing the wider team, because we don't, although we call it GP practice, everybody knows that that means you've got practice nurses, ACPs, AMPs, mental health practitioners that work there, pharmacists as well as a whole raft of other allied health professionals that work from general practice. So it's, year on year we're increasing. The experience is the bit that's the variable. And that's the bit that we're focusing on, and have been last year as well, and going into this year. Last year, one of the positives that we've now got is every single practice has now got cloud-based telephony implemented. We didn't have that a few years ago. We still had just some practices, and some practices were still using old telephone lines. So it's a single telephone line. You ring, it's engaged. You've got to put it back down, and you've got to ring again. And we know that those practices that have been using cloud-based telephony for quite some time, we can see their, patient experience outcomes that are improved, and they don't have the same type of 8 a.m. rush that other practices are experiencing. We're working with those practices that have only in the last sort of 6 to 12 months have implemented technology, and supporting them to get to grips with the technology and look at how they can utilize that technology to the best of its advantage. And that takes time. There's also all the other sort of points of access, particularly things like NHS app, which is great for a lot of people, but not for everybody. But especially for things like repeat prescriptions, etc., is a much better way of accessing that type of support, rather than ringing your GP practice and then being in a line just because you want to try and get a repeat prescription. So there's huge amounts of work going on. There's various elements of work that we are putting in place. We are making incremental improvements, but we know we've got further to go. And I think even last year, despite the fact that we had GP collective action going on as well across across the country, really, and particularly in LLR. Our general practice colleagues still continue to deliver what was needed to be delivered for their patients. I think that's a real positive, but there's loads of work to do, and we're not resting on our laurels. We know we've still got work to continue. The challenge will be how we consistently get that right across 150 so GP practices in LLR consistently, so that we are able to demonstrate that and see that sea of change.
I just observe that a lot of your response to the question earlier on was relying on AI and online, and there's a fairly big demographic of your customers who, like my mother, she can just about use a mobile phone but forget computers completely. And you don't forget that, because it's a massively important issue. And then the other side, you've got people who just can't afford it, or it doesn't work on their phone.
Absolutely, Dr. Hill, and that's why it's not that one size fits all. It's there's a need for those things, and there's a use for that for certain pockets of the population, but it doesn't work for everybody, which is why if we can get the telephone lines freed up for those that need to use the telephone line, and those that can use other technology to access their practice and access the services that they need, that then helps us to manage that overall demand much better.
Any other questions on that bit, Mr. McDonald?
I think in a lot of cases, it's the customer that won't move practices when a new practice opens. I had the misfortune about 5 years ago to change a practice where the 4 doctors were part-time. The service was terrible, and you had to wait 3 weeks for an appointment. And someone at my work told me about this new practice that had opened up. We're down in Salem, filled in the forms, and the system they operate is, if you phone at 8 o'clock in the morning, you'll get an appointment that morning. If you phone at 12:30, you'll get an appointment that afternoon. None of this waiting. Now, even my own family, when they said, oh, I had to wait 2 weeks for an appointment. Well, why don't you go and see the doctor down the road? Oh, no, I've been with him for 20 years. They will not move. So that's a problem as well. I don't know if doctors can advertise or whatever, but I know there's, if you filled in the forms today, you'd definitely be seen tomorrow.
Yeah, GP practices can, if they've got space on their lists, they advertise and they will welcome new patients. It's a bit like dentists. Whilst they've got space, they will take new patients on, a bit like general practice as well. And they do, and we've got some much more proactive general practices that out there that will do that, and you've got some that are much more traditional, that they don't do that necessarily in the same way. So we, like I said, we try to work with a very variable group of people and professionals, and like I said earlier, one size doesn't fit all. So for some patients, certain things are, they've seen their GP for many, many years, they want to stay with that GP. So despite all the other things, that when they get to see their GP, they get the right care that they need, so therefore they don't want to move. So it's about then what do we do with that practice and the GP to improve the other bits to make that better, because yes, people can move, but that doesn't mean that things will still improve at that practice, and we've still got to work with that practice to improve things as well.
Might not be ideal, but there we go. Mrs. Barber, I want to move on to the public health outcomes.
Just one last point. I mean, we've highlighted some issues that have risen out of the report, but I just wanted to touch on the learning disability health checks, because I think that's a real success story. And Healthwatch comes across this from time to time. The rate in the county for learning disability, its annual health checks completed, I think is one of the highest in the country. Well, certainly it's way up there. And I think that the ICS should be congratulated on that, because it really helps people with learning disabilities make sure that they're maintaining the best health they can. So I wanted to say from Healthwatch, congratulations on that one.
Thank you very much. And just to sort of note, we are also we're the only other ICB that's part of a national pilot to pilot the combined health checks. So that's combined health checks for patients with LDA and patients with long-standing severe mental illness as well. So we're piloting that with our general practice in LLR as well. And again, I think if we're bringing in the mental health colleagues, they should be able to pick that up as part of their overall presentation. So I'm sure HOSC members would like to know about that too.
Okay, thank you. Mr. Squires.
Yes, a slightly separate question. So I wanted to ask about access to dentistry. So a lot of our constituents are reporting it's quite difficult to access a dentist, and I think we all have that shared concern. It's more of a concern in rural areas where there's perhaps only one that's in within a bus journey. So what work is there being done to either widen access or improve appointment availability?
So we have a regional team that oversees the dental access for the region and across the region. So what I would do is I don't have all the information in terms of that, but I can certainly get that for you, Mr. Squires, and also maybe worth inviting the regional team, the commissioning team, to come in to talk through with the plans. What we do know, what I can say is that 700,000 additional appointments are being implemented, and we've got a share of those additional appointments in LLR. So what would be probably really useful for HOSC members to know is what the plan is around that and how that is being delivered across Leicestershire as well as Leicester, but particularly across Leicestershire.
Thank you.
Yes, apparently dentistry has been to the Joint Health Scrutiny Committee, which doesn't necessarily help your question, but it has been looked at. But it might be something we want to look at here because it's a county-wide issue, and it's been around for a while but hasn't got any better. So can we move on to looking at the second bit, which is the public health outcomes performance, which is in Appendix 2. You're going to introduce this, Andy?
Yes, if I could just say a few words in introduction. Appendix 2, as I say, sets out the 36 main indicators that reflect on some of the key public health department service interventions and priorities in the health and wellbeing strategy. So we do sort of monitor that on a regular basis and report progress and updates, particularly looking at comparative performance, nearest neighbours, as well as all country performance. The overall picture largely positive for Leicestershire performance. When you look at the all population picture, but not to say there isn't targeted population groups and geographic groups and health inequalities that are still a key focus for the department to maintain some of the performance and improve it. Just picking out a few from the report, one of the green metrics has seen a significant increasing, i.e. worsening performance over the last 5 years. That's year 6 pupil prevalence of overweight and obesity, potentially picking up the COVID tail, I would suspect, and some of the behavioural impacts around sort of COVID at the early start of those pupils' school lives. Paragraph 16 just picks out in relation to completion of drug treatment for non-opiate users. So that's been shown a challenging area to maintain performance over the last few years as well. So that sort of stands out in the figures. And then just 2 red areas highlighted. So that's towards the bottom quartile of our nearest neighbours. Again, around overweight, including obesity, that this time in relation to prevalence in adults. This is for 22-23 when we had the latest data. Last year ranked 10th out of 16. And also HIV late diagnosis in people first diagnosed with HIV. Last year ranked 15th out of 16. So there are a couple of improvement areas. Again, this is all being looked at in the new health and wellbeing strategy. So some of these areas are being picked up with a view to sort of identifying improved focus on some of those areas with colleagues in the NHS. We have had a few areas updated recently since the report was written. So hopefully Victoria Rice may appear on the screen. Yes, I can see Victoria. Victoria, just wanted to update you on 2 or 3 figures that have moved since the report was put together.
Yeah.
Victoria.
So I've just picked out quite a few indicators have updated just due to Murphy's Law of them updating after papers. So I've just picked out ones where there's a significant change anyway. So the inequality in life expectancy for females has gone from the best quintile nationally to the second best quintile nationally. So that effectively means that the life expectancy difference between those in the most deprived areas and the least deprived areas has increased slightly. The next point I wanted to highlight was the overweight adult performance. So the adults who are overweight has gone from significantly worse than the national average to similar to the national average, but the actual percentage has increased from 64.1% of the population to 65.9%. So while we have increased, compared to the rest of the country, we have increased slightly less effectively. So we are now similar to the national average rather than worse than. And then looking at active adults, we have gone from significantly better than the national average with 66.8% to similar to the national average of 70.1%. So again, an increase, going from significantly better to average, so the opposite of that weight indicator. And then inactive adults has gone from significantly better than the national average at 21.4% to similar to the national average at 18.9%. So again, we've seen a decrease, but actually in comparison to the national pattern, we are now similar. And those were just the ones I wanted to highlight.
Okay. So the short answer is, even though people apparently are doing more, they're getting bigger.
Yes.
She's sort of slightly counterintuitive, but
at least according to the data, yeah.
Yeah. Okay, well, yeah, probably borne out by just general life. Okay, any questions about these figures? Mike, you wanted to come in first.
Yeah, a couple of bits for me, just actually picking up on your point, Shared. Yeah, I mean, that's one of the reasons why we're looking at a whole systems approach to food, because I mean, there's two bits to obesity, isn't there? There's physical activity and food. We probably have concentrated, and people do, on getting people more active. But actually it's probably what you eat that overall makes more of a difference. I was going to ask Victoria, I'm going to let myself in for this one. Inequality in life expectancy is kind of good that it's narrowed. You can do it in one of two ways. You can make people who are less affluent better, or you can make people that are more affluent not as healthy.
I misspoke.
Which is it? Because it makes a bit of a big difference as to whether it's a good news or a bad news.
Sorry. It's trying to keep slopes and things in my head, and I misspoke. So for females, it has actually widened a little bit. So we've gone from the best quintile, where they're nice and close together, to further apart.
That's great. It still begs the question of what am I doing? Am I killing rich people or making poor people better?
Can't answer that.
That's one for you to investigate, Mike. I've got Mark and then James.
Thank you very much. I just want to touch on the HIV late diagnosis, because with the prevalence of treatment now, the life expectancy is amazing, and the prognosis, people diagnosed early, is fantastic. You can live with HIV now. It's concerning because it's not a marginal increase, it's a 13% increase, and I just wondered if there was a rationale behind that, because that's a significant increase when treatment is so good now and prognosis is so positive for those people caught early. So do we know why that has increased so significantly?
It's probably a bit out of the purview of my expertise, but I do know that there is quite a lot of work going on within the department on sexual health. And I know from providing the data to the group who look at it that is one of the things they are really looking into. So I can't answer that, but there are people looking into it. Mike might be able to.
Thank you. Mike, sorry.
To suggest that goes on the agenda then. I mean, HIV is not public health as a public health indicator, but it's probably worth bringing in NHS colleagues and public health for a look at HIV late diagnosis.
Okay, yeah, thank you if we could. Mr. Poland.
Thank you. Just a question on the female life expectancy that we just talked about a second ago. When we've moved down from the best quintile to the second best, is that likely to be because of something we've done or not done, or could it be because the rest of the country's got better? If you see what I mean, because obviously that's a relative stat to everyone else. If you see what I mean.
Yes. So. We have gone from that the best quintile to the second best, but we have also seen an increase. So the gap has got bigger. So there definitely has been something that's got worse, but we also may have not, how to word this correctly is quite difficult. The country may have done better than us as well. So it might be a combination of both, but we have increased the slope.
That's one to be looked at. Because the national trends will influence how we look locally. Yeah, needs a bit of unpicking, I think, fundamentally. Okay, any other questions? Just an observation, is the x-axis, got to get that right, no, the x-axis on these, are they annual figures for the trend? Thank you, Mike. They are annual.
It will depend on the indicator.
Yeah, most I think are annual.
Yeah, most of them probably are. Some of them will be longer term for certain programs and things. It depends.
Yeah, okay. I mean, it's good because you get a decent trend figure for what's happened over time. And like the HIV one, suddenly went doing, you know, oh, hello, what's going on there? So yeah, okay, that's great. Mike, just briefly.
Yeah, just on that one, because I was looking in relation to the previous question when we did our item. So the second indicator on page 155, it's not DMFT around children's dental health, as I was saying, but it's percentage of 5-year-olds with experience of visually obvious dental decay. And again, I think it kind of bears out what I was saying. That first dot on the left-hand side would be 16, 17, tracking it through to 21, 22. And you can see that we reduced, or it reduced, I won't take credit for it, markedly from nearly 40% of 5-year-olds with experience of tooth decay down now to below 20, albeit it's gone up in the last one. But coming back to my comments, so we've gone from a position of being well above the national average, that was the relegation zone, to now being below the national average. But I do note in relation to our near neighbours statistical rank, we're still 12th or 14th. So relatively, we're still the Leicester City last year, not Leicester City 2015-16.
And worth noting that it was one of the other indicators that updated, and we're still in the green, and it's now at 17% rather than that 19%. So it's gone down further.
Any other questions? Well, thank you very much. Fascinating as always, and very useful. And we'll no doubt see you again. We do these quarterly, don't we, if I remember rightly?
Every other meeting.
Every other meeting there's a voice to my left. So yes, thank you. So yeah, thank you. We'll just finish the agenda off before we do our briefing. The date of next meeting is the 3rd of September. We have no other urgent items. So I will close the formal meeting and we'll do our separate briefing. So thank you very much.